Nitin Jain from the Department of Leukemia and Cancer in Houston, and we are in Houston for SOHO 2024. I'm so delighted to have Dr. Bijal Shah from Moffitt Cancer Center here with us today. And over the last decades, we have seen the cancer care evolved from use of surgery many decades ago, radiation, then chemotherapy, then maybe about 2 decades ago, development of targeted therapies such as Gleevec or imatinib, I should say, for CML. And then I think in the last 10 years, 15 years, we have seen immunotherapy, checkpoint inhibitors for solid tumors, also some heme malignancies. And also, I think increasingly we are seeing targeted antibodies, bispecific antibodies, and then also CAR T-cell therapy. First approval, Bijal, happened about now in 2017, right, for children with ALL. So I think we're in a very exciting field of this CAR T-cell therapy, already approved for lymphoma, myeloma, and ALL. And for the main purpose of this discussion, let's focus on ALL, and maybe we'll focus on adult ALL a bit more. So I wanted to see what's your viewpoint of how you see CAR T-cell therapy. Maybe give us a flavor of what are the approved agents, what's happening in the field, and then how are you kind of maybe trying to use these CAR T-cell therapy for your patients?
Absolutely. I think, let me start by saying I was listening to the interview that you did with Dr. Hagop-Katarjian, and it's amazing when you step back and reflect over what's happened in the past 20 years. Going from, in the case of pH-positive
Sure.
ALL, where we considered it one of the highest risk subsets of
Right.
ALL that we would see, to now considering it standard risk.
Right.
Because of the inclusion of not just TKIs, right? But these very potent TKIs.
Sure.
And now, with the advent of immunotherapy, again, bispecific blinatumomab, moving to curative therapy without chemotherapy.
Right.
I never imagined that I would be having that kind of a
Sure.
conversation with
Right.
you today. So when we talk about the pace of approvals, I think what we've really seen has emerged since around 2013.
Right.
Beginning with the approval of blinatumomab,
Right.
then inotuzumab, then tisagenlecleucel
Right.
for pediatric ALL,
Right.
and finally brexucabtagene autoleucel
Right.
for adult ALL. That's paralleled also the development of TKIs, as I mentioned a few moments ago, imatinib, dasatinib,
Right.
ponatinib, and although used off-label, nilotinib, bosutinib, just this steady march
Sure.
with one central premise. How do we make it more effective, but at the same time improve on the toxicity that the
Right.
patient's lived experience?
Right.
So I've been incredibly blessed to see that happen. I also treat aggressive lymphomas, and I can
Right.
tell you, being able to see that development pattern
Right.
in aggressive lymphomas as well has been extraordinarily rewarding.
So, so this is so as you mentioned, so Tisacel, which is approved for children up to the age of 26 years with B-cell ALL, and then Bruxucel, which is approved 18 years and older. So in your practice, I'm sure a lot of adult patients are these days getting Bruxucel as a CD19 autologous CAR T-cell therapy. So I think it's good for our audience to see, like in a multiple relapse refractory patient, adult patient who has probably have seen maybe blinatumomab already, inotuzumab, many of them had allo transplant already. When you're using Bruxucel, because that's the only approved adult product, at least in the United States, what kind of expect? What can the clinicians kind of expect, tell the patients how much to expect in terms of the toxicities, also obviously importantly response rate, 1 or 2 year outcomes? Can you comment on that? Because I know you are the lead for that
Absolutely.
study.
Yeah, exactly. So, the hard part is to say, what does it mean to be triple class exposed, right?
Right.
And when I say triple class, inotuzumab, blinatumomab, and allogeneic stem cell transplant. That's a harder one to answer because I don't know that I have large numbers of patients
Sure.
in which to predicate that data. Personal experience, around 40% long-term survival.
Okay.
And what's amazing, that mirrors what we're seeing from the pivotal KITE sponsored trials of brexucabtagene,
Sure.
right? 4-year overall survival of 40%
Right.
in heavily pretreated
Right.
population. Again, just to give you some
Sure.
perspective,
Right.
half of the patients had prior transplant,
Right.
half had prior blin,
Right.
a quarter had prior INO.
Sure.
It was an extraordinarily heavily pretreated patient population. And the groups that didn't, you say, well, what about the half that didn't?
Right.
Primary refractory, where actually we know from our own clinical experience, those patients do not derive the same benefit from the novel agents.
Right.
And so extremely exciting to look 4 years out and say, yes, 40% of the patients remain alive. And here's the fascinating part, independent of what we did next, meaning
Sure.
subsequent transplant,
Right.
subsequent therapy, didn't seem to change that survival estimate.
Sure. I think in terms of maybe looking forward, I think, maybe you can talk to us about maybe what new maybe CAR T products are coming along. Are they still looking at CD19? Maybe you and others are looking at combination strategies, maybe 19, 20, 22. And maybe also, maybe I think a field where the field is moving in maybe earlier lines of therapy, maybe you want to comment on that as well.
Absolutely. I think right around the horizon, we're going to see the approval of obacabtagene autoleucel, right? So this is a CD19-directed CAR T-cell product, but it takes advantage of a couple of different approaches.
Sure.
One, a split infusion,
Right.
where patients who are not having severe toxicity will go on to get the next dose.
Sure.
The idea here being to try to ensure that we're not putting the full dose in
Right.
at the same time
Right.
and seeing a higher toxicity
Sure.
signature as a consequence.
Right.
The second piece to this,
Yeah.
the low affinity CD19 binder.
Right.
The hope being that you can bind in a more physiologic manner
Right.
and avoid excessive toxicity
Right.
as a consequence, excessive cytokine production
Sure.
in particular. And then, the other unique thing about this product, again, has to do with lymphodepletion,
Sure.
has to do with the tumor burden of patients that we
Right.
treated. There's so many other factors that
Right.
play into this, but it is one thing we can say quite comfortably.
Right.
It is no longer hypothetical.
Sure.
We are seeing less CRS, and we are seeing less ICANS for the whole population.
Right.
Very, very encouraging.
Right.
So this is where we stand with the 19.
Sure.
What about moving beyond 19?
Right.
In ALL, we're starting to see allogeneic CAR products,
Right.
and I think you actually lead one of the CD22-directed
Sure.
allogeneic CAR
Right.
T products. And a question that will inevitably emerge,
Right.
because there are autologous
Sure.
CD22-directed products.
Right.
How will that enter the ALL space? What will be the development there?
Right.
We know that Bijal Shah from the NCI,
Right.
using their construct, has also been exploring this. And one of the big questions she has is, should we wait?
Right.
Should we wait till someone relapses, or do we move in with 19 followed
And
immediately by
22?
22? BAFF-R-directed
Right.
CAR T cells.
Right.
This is being developed out of the City of Hope.
Right.
I think also extremely encouraging, very early data.
Right.
Two or three patients have been reported on with mantle cell lymphoma.
Right.
But very intriguing in terms of its activity,
Sure.
meaning it's extremely active.
Right.
These two mantle cell patients had both had prior CD19-directed CAR
Sure.
T-cell immunotherapy, and both developed MRD negative responses
Right.
after the infusion. ROR1 is another evolving concept,
Right.
and so we'll see how those trials
Sure.
will ultimately shake out. And then we've been talking about T cells this whole
Right.
time. We have to keep in mind that there are natural killer cell products that
Sure.
are out there. There are gamma delta T cell concepts out there. There are even folks trying to look at dendritic cell
Sure.
based approaches or monocyte macrophage based
Right.
approaches. And so I think what's amazing is learning that we can
Sure.
indeed use the immune system to help us achieve these
Sure.
extraordinarily deep remissions. And then, at least for me, as I
Sure.
project forward, what will we do next? And before I even go to combinations, the first thing that absolutely has to happen, if we're really going to make this real
Sure.
for every patient that
Right.
needs it, is improving the delivery
Sure.
process.
Right.
That's not simply a toxicity question. And again, while I'm excited about
Right.
obe-cel, I have to be honest at the same time that for those of us who treat with
Right.
CAR T routinely, the CRS and the ICANS are largely manageable.
Sure.
The likelihood of seeing someone pass away from these toxicities is quite uncommon.
Sure.
Infection still predominates as the main risk, and that's a function of the therapy itself.
Sure.
The delivery, though, right? One approach is an allogeneic CAR T approach, and I
Sure.
mentioned that with the UCART, but I want to go a step further. In vivo CAR T cell is, I think, again, if it works,
Right.
there's no question in my mind that that's the future.
Right.
And the way that I'm seeing,
Right.
companies develop this, so that you have selective expansion.
Right.
Because that is the key, right? They have
Right.
to. It's not just about getting the CARs in the body;
Right.
they have to be able to grow.
Right.
But the approaches that the folks are taking, and I'll mention Emoja just because that's
Right.
a group that we're trying to partner with
Right.
now. There are others. it's extraordinary. It's extraordinary and has the potential to completely take the field in a different direction when we talk about CAR T-cell immunotherapy. And again, ALL has to be part of that equation.
Right.
Where are we going in terms of combinations? I said I would come back to that.
Yeah.
I think the initial thought was CAR T has to be standalone.
Sure.
Nobody believes that anymore. We're seeing it in lymphomas where we bring BTKs into the CAR T paradigm. That's the Tarmac study. There's also other studies using pirtobrutinib, which I know you're quite familiar with, and other TKIs. What about other TKIs? What about our ponatinibs, our olverembatinibs, our asciminibs? You're going to start to see trials that build on that.
Sure.
Revumenib. You know, one of the things that we worry about in MLL rearranged leukemias is antigen. Is the loss of CD19 progression with either a myeloid type phenotype. We might have the potential to prevent that using this combinatorial approach, almost like a CML blastase. And so these combinatorial approaches are exciting, but I'm going to go even two steps further. Where am I also excited? The idea of using bispecifics.
Sure.
Why? What if bispecifics do more than simply treat lymphoma? What if we're actually getting antigen-specific priming, you know, the holy grail, that we then turn around and expand and activate in the process of manufacturing CARs, and we put that back into a patient? We may have the potential to increase our cure fraction beyond what a CD19 CAR is capable of. And I think there's a lot of interest and excitement. We have to figure out how to make this a reality. I know those trials are ongoing, but extremely exciting from where I'm sitting. So you asked me a big question, you got a big answer.
Yeah. No, this is fantastic, Bijal. I mean, I think what you summarized here is how the field is currently, but also I think a lot of positive developments which people are thinking about. And I think we'll have to see how the next maybe 3 to 5 years hold up in terms of all these developments. And I'm sure some of these will pan out in clinical trials and maybe eventually lead to positive outcomes for our patients. So
what I imagine is, and again, you know, this is a trial that we're doing, is that CAR Ts replace everything. And so speaking directly to that, this frontline CAR T cell trial, right now it's for folks who are MRD positive after one cycle of induction moving directly to a CAR. Nitin, what I envision is that MRD goes away. We simply debulk and CAR. That's it. If we optimize with a bispecific, if we optimize with a TKI, if we take this approach, I think we could actually talk about humanely delivered therapy, not 3 years, 2 months, something that lives up to the promise of what we all hold true, which is preserving both longevity and quality. And I think if we take that a step further with the in vivo delivery systems, we're now actually partnering with our community physicians. We're able to do this in a way that is easy. Am I allowed to say that?
Yeah. No, this is fantastic. So I think, we're here again with Dr. Bijal Shah from Moffitt Cancer Center, and he nicely summarized where the CAR T-cell therapy field is currently and what to look forward in the next few years. So thank you again, Bijal, for coming to SOHO 2024.
Nitin, thanks for having me.
All right, thank you.